Congenital nystagmus is an involuntary, rhythmic, pendular, or jerky conjugate oscillation of the eyes and occurs in a manifest and a latent form. Common causes of manifest congenital nystagmus are congenital cataracts, congenital glaucoma, aniridia, achromatopsia, Down syndrome, and high myopia, optic nerve hypoplasia, Leber's amaurosis, and oculocutaneous albinism. Sensory defect nystagmus is caused by inadequate image formation on the fovea as a result of anterior visual pathway disease. Sensory defect nystagmus is always bilateral and horizontal and often is of the pendular type in which the eyes oscillate with equal velocity in both directions. Motor defect nystagmus is caused by a defect in the efferent mechanism, possibly involving the centers or pathways for conjugate ocular motor control. Spasmus Nutans is a small amplitude, high frequency, horizontal nystagmus in one or both eyes that is accompanied by head nodding. Spasmus Nutans may be associated with optic nerve and chiasm gliomas, empty-cellar syndrome, or a porencephalic cyst. Congenital nystagmus is characterized by a slow drift of the visual target off the fovea, followed by a rapid saccadic correction movement. Manifest nystagmus usually occurs with equal amplitude and frequency regardless of whether both eyes are open or one eye is closed. In manifest latent nystagmus, the nystagmus intensifies upon occlusion of one eye. In manifest nystagmus, it is necessary to determine visual acuity by covering either eye and with both eyes open. Binocular acuity is higher than monocular acuity when a superimposed latent nystagmus is present. In nystagmic patients, visual acuity at near fixation is dramatically better than at distance fixation. Some patients with manifest congenital nystagmus are able to decrease the amplitude or frequency of the nystagmus by superimposed vergence or version innervation, known as dampening or blocking. Blocking or blockage has been defined as an innervational impulse to bring one or both eyes toward a position that can reduce or suppress the innervational impulse causing the nystagmus. The decrease of the nystagmus by adduction or convergence may be etiologically significant in causing esotropia and introduce the term nystagmus blockage syndrome. Maintaining the eyes in a peripheral gaze position by sustained innervation of yoke muscles involved in lateral, vertical, or oblique gaze causes dampening of the nystagmus. Visual acuity usually improves with the eyes in this peripheral gaze position that termed as null point, and therefore, the head shows anomalous head posture. The head may be turned to either side, tilted toward one shoulder, or the chin may be elevated or depressed depending on the position of the null point. The combination of infantile esotropia with latent or manifest latent nystagmus has become known as the Ciancia Syndrome.